Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
What if I told you there's a number on your monitor that can tell the future? Today we're going to discuss 3 specific situations that utilizes end title, which is my love language. We're going to talk about ROSC, we're going to talk about DKA, and we're going to talk about trauma hypotension and how you can use your little end title CO2 cannulas to help differentiate.
Our goal today is that every listener walks away confident in ventilation, perfusion, and metabolism interpretation.
Through end title CO2.
Oh,
because
yeah.
We love her.
We love her.
All right, Soph, what are we starting talking about?
Well, let's talk about what end title CO2 actually tells us. So, first off, let's stop thinking of it as just a respiratory number. I think a lot of the time when we're getting into end title, people just think respiratory, but it can tell us so many things. Okay, we're going to break it into 3 different pillars here for end title. It reflects metabolism, perfusion, and ventilation. So with metabolism, that is how much CO2 your body is making. With perfusion, that's how well we are delivering CO2 to the lungs. And then ventilation, of course, is whether or not you're blowing it off. And we have come up with some nice little mnemonics for us because we love a mnemonic.
Oh, yeah.
Let's talk about high end title. So we have hover. And you can just remember high is hover because it is above. Hypoventilation for H. O is obstructive lungs. V is vent failure. E is excess in metabolism. And then R is rebreathing. And quickly we'll go over low end title, which is pedals. We have P for poor perfusion, E for early shock, T for thromboembolism, aka PE, and then A, airway issues, L, low metabolism, and then S, significant leaks. So now that we kind of know what end title is, which I know that probably all of you do, I hope that you do, let's kind of take it a little bit deeper and talk about ventilation and where we use it. This is kind of like the most common thing we think of when we think of end title is ventilation monitoring. So
we're going to talk about ventilation and mastering ventilation. So at first, when you want to learn about end title, you have to figure out what normal is. So normal end title is 35 to 45 millimeters of mercury, but your waveform is what's going to give you the most information about that patient's ventilatory status. So let's walk through different waveform patterns. So you have the shark fin, and it legitimately looks like a shark fin. And so this is bronchospasm or air trapping. So you'll see shark fin a lot in like COPDers, a lot of times even when they're not in distress because they have some level of air trapping. Then you'll have low amplitude. Low amplitude end title can mean one of 2 things. One, it means that you're doing poor compressions if you're doing CPR. So it's a great monitor for your compression depth. Also, they can be in shock. Next is going to have your high baseline. So in this, your end title square, it does not return all the way back down to the bottom. It will come down like partially, halfway, quarter of the way, whatever it is, and then it will go back up. And so this is your rebreathing because they're not going to exhale all the way. Then you have your curocleft, and this is an indication for inadequate sedation or paralysis. So if you have an intubated patient and you're seeing a curocleft, then and we'll show you, we can have like pictures, we'll post a bit, but this cleft is going to indicate that they are taking a breath during a ventilation breath. You can also actually see this without an intubated patient, but it does not mean the same thing if they're not intubated. And
Yeah,
that's-
please don't see this and be like, should sedate.
Yes.
Yeah, this QR cleft,
Absolutely.
if you see that, there's a good chance they're just going to start accumulating CO2.
Absolutely.
So that will go up too.
And when you see that kind of pattern in a patient that is not intubated, if you watch them, a lot of times they're taking a breath during a breath. Like you'll see that they'll inhale and kind of do this like,
You know, those little baby hiccup, like when a
Yes.
baby is like crying.
yes, like, yeah, like, or if you cry really hard and you do the thing,
Yeah.
that will, that's kind of what that waveform will look like. And then lastly, and not only, but the last big one is our VQ mismatch. And this is going to be like a roller coaster shape. So it's just going to be like these big up and down hills.
Yeah, nothing looks right.
Yeah. So a practical example is that you have an asthma patient, right? They have rising CO2 and a shark fin, right? So they're not getting rid of enough CO2, and their waveform shows that they're air trapping. So that's impending respiratory failure, which kind of your treatment really is based on your protocols. So follow all your local protocols, but it's going to be BVM, MAG, NEBS, and then prepare for RSI. Now, in these patients, RSI is not necessarily your first option, right? Intubating asthma patients doesn't fix your problem. It just makes you feel better about it,
Yeah, please don't.
right? So the shark fin that shows your air trapping, that gives you a great indication into what's actually happening with this patient.
And obviously, like, read into more than just your monitor and things like that.
For sure.
But in next episode, we're actually going to be talking about CPAP versus BiPAP. So
Yeah.
that should be fun. Perfusion and shock. I love using it for this. I love using it in major traumas. You should obviously absolutely be using end-tidal and a code, but I really, really love using it in sepsis and in trauma, which is covered in this section. So your perfusion is impacting your end-tidal CO2, but let's just like talk about a mini case here and discuss a case of perfusion inadequacy. So we have an elderly fall victim with some vitals. Maybe we have a soft pressure. Maybe they're they're not tachycardic or anything, but they have an end-tidal of 20. So
Ooh.
that could be a little concerning, right? That's why I love end-tidal. Okay, so they have a soft pressure. They fell. They're on blood thinners. What are we concerned for, maybe?
Some kind of bleed somewhere.
Yeah. I mean, they're fragile. We talked about this in a previous episode. Like, they be bleeding from nothing. They could roll out of bed.
Yeah, like ground level falls out of bed, falls out of chairs.
Yeah.
All of which can cause significant trauma.
Yeah. When you ask her, she tells you when she fell, it hit her abdomen on her walker.
Yeah.
Ooh.
It's a red flag, right?
For
It's
sure.
a red flag.
So, not only we're going to do a patient exam, but that end-tidal is just a confirmatory factor that not only do we have an elderly patient who fell, who probably has some bleeding, they probably need a trauma center. Just because it was a ground level fall does not mean they don't need a big trauma center.
For sure. And like Mama, if her pressure is, let's say her pressure is 100 systolic and her heart rate's 70, I'm not worried about her.
Yeah.
Those are like very reasonable
That's
vitals.
normal. Yeah.
Especially if she's
a little
small.
memo.
But let's say that is actually soft for her because she's a history of hypertension. Her heart rate's 70 because she takes beta blockers.
Yeah, an end-tidal of 20?
And her end-tidal's 20. That end-tidal of 20 is what's going to be like, make me clue into those vitals and be like, those actually may not be an accurate representation of her status right now.
Yeah.
Yeah, I feel like with this patient demographic, you can't rely on shock index at all because there are
Nope.
so many beta block patients, and you don't always see a lot of tachycardia. So
Yeah.
end-tidal is a great indication for these patients.
And
For
that
sure.
is very low end-tidal.
Yeah.
Yes, it is.
So when we recognize these things early, we can get them to where they need to be. We can get them to the right facilities. You know, you can justify things too in your documentation, and we don't live by, STYA, but it is a nice confirmatory number.
Yeah. And a lot of times with these patients, like you may have already decided this is what was going on based off your patient assessment. You may have seen a bruise on her abdomen. She may be getting a little distended. You may have been able to physically assess those things, but to have a number that supports what you think is going on is
Yeah.
fantastic.
Absolutely.
Yeah, I know we've said this before, but at the very basic use of using end tidal, like if you're not on board with using it for things other than respiratory, think of it as, at the very least, a documentation tool, because it is something that is hands-off, automatic, and easy to document.
Yeah, the same way that I'm like, well, they were hypotensive, so that's why I think X, Y, and Z. You're like, well, their end title's 20, that's why I think X, Y, and Z.
Yeah.
Absolutely. And a lot of the kickback I have gotten, and I know you guys have too, is that like, well, we didn't have end title when I was on the truck.
Yeah.
That, like, quote, I'm like, okay, but also you didn't have 12 leads.
Yeah.
Correct.
There was also a time where there may or may not have been oxygen.
Yeah.
Doesn't mean that it's not useful.
Absolutely.
Yeah.
So new tools are important, and
sure.
we are evolving. Please evolve with the system.
Now, so what about like CPR?
I love it. So I think especially in the times where we're like, CPR devices are unreliable. I have a lot of feelings about that. We've discussed this. But this is a great indicator if you're getting quality compressions.
Absolutely.
So, like, whether you're using a device or manual CPR, like, this is going to tell you if perfusion is happening, is blood going round and round.
Mm-hmm.
So, when we're in a code, our goals are a little bit different. We're not going to get the same end title, obviously, if this person had a beating heart on their own. And also depending on what caused them to go into arrest.
For
this
sure.
could be different. But we want to generally aim for like 10 to 20. And then if you see a sudden spike, there's a good chance you have a pulse. There's been times where we've had a sudden spike and we couldn't palpate a pulse. We continued CPR and things, but we were like, for sure, they still need a little bit of support with compressions and things like that. But we probably had ROSC before
and
we
that's
even finished.
That's a great thing to point out, where at that point you start considering like pressors and other things that you can do. Are they still volume down? Yeah, if you've had a jump in end tidal.
For sure.
We're just talking about putting end tidal on like after you've gotten an advanced airway though, right?
Absolutely not. So I think what a lot of people think is that your end tidal is only useful in either 1, a spontaneously breathing patient with a nasal cannula, or 2, an intubated patient or a patient with like a eye gel or whatever it is placed. But no, there are plenty of ways to monitor your end tidal if you are ventilating somebody in a BLS manner. So all of the ET tube end titles, they also fit onto a BVM between the mask and the bag, which is fantastic.
And then it's one less thing that you have to think about because it's already on your BVM. So if you get an ET tube placed, then you can just take the mask off, keep the end tidal on, and slap her on there.
And that is also a great way to confirm if you have a decent seal or not.
Yeah, that is true.
If you're getting a trash end tidal reading or, really no waveform at all, then your seal's probably not very good on your BVM. You can also use, there's end titles that there's a port on your BVM that your end tidal plugs into. So it doesn't even have to go between your mask and your bag. So you should be monitoring end tidal at the very beginning of your resuscitation before you have any advanced airway placed.
Absolutely. Just use end tidal everywhere for everything. That's what I think. Also, I've had some insane sudden spikes in end tidal, and it like warms my heart when you see it and you're like doing a code, you're working a code, and then you get that spike. The highest spike in end tidal, which was on a Zoll monitor, I think certain monitors only go up to a certain amount, but it was 136 with ROSC.
Dang!
It was a COPDer who went into arrest.
Wow.
The craziest. That's the most high I've ever seen it go.
Yeah, normally what I see is like between 70 and 80.
Yeah.
Like our last 2, we had a ROSC like last week, and it was in the 70s, and we stopped. And then I was a supervisor at the other shift and had one, and it was 80.
Yeah. It also depend what caused the arrest, how high you're going to get.
For sure. But it's just such a fantastic tool. It was a moment where there's a lot of things going on. I looked up at the monitor. I saw that end tidal jump to 80, and I was like, everybody pause, check for a pulse, and there was one.
Yeah. It's awesome. That's how simple it is, guys.
It's great. And if you aren't watching CO2 during your CPR, then you're essentially doing a blind resuscitation. So I think that that's important to think of it that way.
Yeah.
That if you are doing compressions and you're trying to check every 2 minutes, we all know how good everybody is at following the times in the ACLS algorithm when you're doing 100 things. you forget to check and to do all these things. And we don't want to cause more trauma than is necessary for these people that we're resuscitating. And so if you have end tidal and you can monitor it and wait for that jump, and that's when you make sure you're checking pulses, it's a great tool.
Yeah, I agree.
Why aren't we doing this, you know? I mean, we're doing it, but, like, it's so easy.
I
it's
hear
just
a lot of companies be like, well, it's expensive. I'm like, that is the most sorry-ass excuse for not providing adequate patient care.
correct.
Yeah.
Yeah.
It's not that expensive also.
It's
We've
not.
looked it up because people have told us this before, and it's not that expensive.
Yeah.
It is no more expensive than the other run-of-the-mill equipment you have on your truck.
Guys, do you know how much glucagon is?
Oh,
We can
my
use
gosh.
end tidal.
You can use a couple end titles a shift.
Faux
Promise.
All right. Not only can we use this in patients with ventilation issues, oxygenation issues, perfusion issues, we can also use this in one of my favorites also, which is acid base and DKA considerations.
So, what do you think that their end tidal would be, high or low, for DKA? Because I feel like this is kind of like a little mind trip.
I
Well,
can see that.
obviously,
Yeah,
it would be high,
obviously, because they're so acidic, right?
right?
Wrong.
Oh my gosh, explain.
So, we all know the compensatory mechanism with DKA, right, is those super deep, rapid respirations, because that is your buffer system, right? Your body is trying to blow off all of this CO2. Because of that, because we have such deep, rapid respirations, you are hyperventilating, right? So your end tidal is going to be low. So I know that that's kind of, it feels backwards in your brain. You're thinking high acidity, that I'm going to see a high end tidal. Not the case. If you just think about it for like 5 more seconds, you can get there. But, so if you have somebody that you are suspicious of already in DKA, obviously we all have glucometers. We can see that way. But this is just, again, another confirmation
Mhm.
and another very easy way to be able to document that respiratory rate.
Yes. And if
And-
you think about acidosis and you think about your respiratory compensation, right? Because that's what we're talking about, is the compensatory mechanism. You would have a high end tidal if that patient was not compensating.
Correct.
So they're compensating for that acidosis by lowering their end tidal, by breathing deeply and rapidly. And so I think that that's where everyone gets stuck, is they forget it's the compensatory aspect.
Yeah.
Like, this is the point, is to make it lower.
Yeah, it is working.
And also, a
Your
lot
body
of
is working.
DKA patients are usually young and healthy,
Mm-hmm.
because most of the time, I'm not going to say all the time, but most of the time, that's when you have your first, like, diagnosis of, like, type 1 diabetes is through some significant DKA
Yeah.
event.
Mm-hmm.
So it's nice to have all the ammunition you can to convey to the hospital how sick this person is.
For sure. So let me pose you both a scenario. All right, so you get called 15-year-old male, unresponsive, not agonal, breathing super fast, say like a rate of 50. It's really deep. Parents are clearly freaking out. You get there. They are all of the things that look like DKA, right? Sugar's like 420. They didn't know he was type 1, but apparently he is.
His sugar is 420.
Yeah.
Is that a sign? Is he high? Be honest with me.
He's high.
Oh my god, I knew it. Okay,
Well, his
continue.
entitle's not. Let me tell you that.
But there's a couple different factors going on, right? You have to remember that type 1 diabetics don't have to have their sugar as high to be able to be in DKA. So don't expect to see like a greater than 600. That doesn't always have to be the case. But then you get him in the truck and he is like unresponsive, right? So you're worried about airway, all the things. You put him on an end tidal cannula and his end tidal's 17. What do you do?
You let that ride.
You give him fluids.
Right? Do you
Yeah.
you don't want to control his airway? Like, what if he can't control it?
Well,
How
he is
is he
controlling it.
controlling it at this moment?
I mean, yeah, I guess. Like, he has a gag reflex and everything.
Just
Okay.
make sure you have your
Ballin'.
suction out if you
Yep.
need it.
Right?
Because the last thing that I want to do, even though you walk in and this patient looks like, oh, death on a cracker. Oh, you are obviously in respiratory failure because your respiratory rate is over, I don't know, what's the magic number, 50 or whatever the books say. The last thing that you want to do is take away this patient's compensatory mechanism. You are not going to be able to ventilate at the same rate that this person is breathing. Okay, so why Do you need to use end-tidal on DKA patients when you can just smell their fruity odor?
Because I've never done that before. I don't want to get that close to you.
Well,
If anything, their vomit smells fruity.
yeah. And Aurelius, you can't smell anything, so
No,
you need all
I
the
have
tools
no
you can
sense
get.
of smell, guys. Never been able to smell alcohol. Never been able to smell
Also,
DKA.
I just don't
nothing.
think that that's a reasonable. Like, they smell sweet.
Right.
Diagnosis.
They are not acting sweet, but they smell sweet.
They could have literally been chewing juicy fruit. We don't know.
Yeah.
I might also think that I like measurable data.
Yes.
I like things that I can write down and say definitively, like, this is a data point. And patient sniffed like sweet snoofs. Is
That's
not,
weird, guys.
Like,
Just
I
for the
can't write
record.
that. I
Okay.
can't document
Yeah.
snoofy snoofs.
Well,
like,
you would have never made it through the 80s. That's
Okay.
all I
Well,
gotta say.
see.
I mean, thank God.
However, I can document an Title 17.
Yes, for sure.
Right.
All right, you won me
And
over.
At this point, I'm not necessarily attempting to justify why they're in DKA or why I think they're in DKA. I'm honestly trying to justify why I'm not intubating them. Like,
Right.
I'm trying to write down and justify, like, why it is not in their best interest to, quote unquote, control this airway.
Yeah.
Because, as you pointed out earlier, I cannot bag them at the rate that they're breathing. And not necessarily that I can't bag at a rate of 50, because I can, but they will not be using any of their muscles to expire. And so we're essentially going to be breath stacking at a rate of 50. And then the vent can't keep up with anything either. So we're not tubing anybody.
Ballin'. In this next segment, we're going to talk about trauma and how it correlates to end tidal. But first, I would just like to say, when I actually was just finishing up medic school, I ran a call with Soph. We were working together. I had the privilege. Wonderful. And we went on a trauma call. And Soph put end tidal on this person. And I was like, okay, yeah, we're giving pain meds. Cool. No big deal. And then we watched as this person they were bleeding.
Exsanguinating.
Yeah, profusely. Inside of their body though. And we watched the end tidal trend down like in real time. And so I'll never forget this. She just pointed to the monitor. She said, "They are bleeding."
It sounds like me.
It does sound like you, yeah.
I love to call out the danger numbers. My partners hate it.
We're in danger.
60, 54, 40. Austin's like, I'm getting the atropine. Shut up.
Ding,
Sorry.
ding, 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 ding. But I don't think that this concept made sense to me, or even that I really realized
about
that
it?
it was a reality, until when I got to see it in real time, and it obviously has never left me since that moment. So, let's talk about it. Somebody else talk about it.
Okay. So I do like using it in bleeding. I think it's a great indicator because a lot of the times in, major trauma patients, we can't see all their bleeding. And it's, a good initial indicator. Does this patient need transfusion, right? So there is a difference between the low perfusion of, like, in a cardiac arrest, what you might see, versus, like, in a bleeding patient. But like Aubrey said, you're typically going to see it trend down. But it's, again, too, like, it's not going to be the same kind of waveform necessarily. But this patient needs blood. Okay.
Let's say you have a trauma. Let's say you have a trauma patient and you're concerned that there may potentially be bleeding. You look at their vitals and say this is a 40-year-old male. It's like 6'2". Right? Decently healthy. Look at vitals. You got a pressure 110/60 and our heart rate's 90. Okay. Like, that's not terrible. And then you look at your end tidal and your end tidal's 26. He's not hyperventilating. We're chilling. He's complaining of, like, some mild lower back pain. Right?
Oh my god.
And he just doesn't feel great.
Recently my partner and I had to defend which this was to a coworker, not to, like, anything crazy, but, like, defend our rationale between of why we administered blood products. And I think that there is a strong statement here in trends, right?
Yep.
If you have an initial end tidal of, like, 35, and then you look again and it's 22, but their blood pressure, it's kind of borderline. But what is this person's? Because I can tell you right now, my husband's blood pressure right now is uncontrolled and hypertensive. Like, he's ridiculous. But you know what I'm talking about? Like, we don't know what someone's normal is.
Right?
So I think it's an additional confirmatory number that, like, things are not headed in the right direction.
For sure. And your end tidal is going to show up lower far before your vitals are going to start to
Absolutely.
decompensate. And so if you look and they have an end tidal of 26, why do we think their end tidal is low? So when you think about the actual process of someone having a low end tidal in a low flow perfusion state, it's because their body is not bringing back the CO2. It's not that it's not creating it. It's not that you have a metabolic deficiency in CO2 creation. It's that your blood flow is low, and so there's less CO2 returning to your heart, which means less CO2 returning to your lungs.
Right.
And that's why your end tidal is low.
The only thing additionally that I would have anyone consider, which you can just very glance look at your patient and tell this, are they in a lot of pain and hyperventilating?
Mm-hmm.
Just consider that too before you
For sure.
administer a whole blood or something.
Absolutely. Yeah. Go through all of your other points of contention as to why this may be the case. We also, you can consider, and this is with any patient population that you are monitoring CO2, if they are spontaneously breathing, make sure that they're actually breathing through their nose if you have like an end tidal cannula, or look at how they're breathing, because sometimes the CO2 end tidal will not pick up super accurately if they're like mouth breathing aggressively.
That's fair, yeah.
So just make sure that you look. And if your patient is breathing normally and their end tidal is 5, look at how they're breathing, because that's probably more of the problem. You got to troubleshoot every now and again.
Also, along those notes, is when you first plug in your end tidal and you have to calibrate it, that little solid line at the end. I don't know how it works on Zolls. I don't know if it's the same way, but on life packs, you have to wait till that line is solid at the bottom. I know that kind of sounds like stupid. We don't really do anything by the book in EMS. I will say do that, because I have had a patient where I've put end tidal on them really for no other reason than like documentation sake, and it came back at a reading that I was not expecting, and like this, it did not match the patient presentation or the like pathology. And I was like, that's not right. And I unplugged it, let it recalibrate, plugged it back in, and it was completely normal reading.
Right. So how do you calibrate in the beginning? Like, what's the steps?
The steps are you plug it into your monitor. You do not place it on the patient. So usually what I do is I plug it into the monitor. I set it on the patient's chest. I do other things. Once I look back and see that completely solid line at the bottom of your screen, that means it is calibrated and it is ready to place on the patient.
Perfect.
And I do want to point out, we learned this recently. Not super recently, but recent enough that it is concerning. So most of your end tidal nasal cannulas, the way the oxygen is delivered, if you have it connected to oxygen, is called cloud delivery system. It is not going into their nose holes.
Yeah, it does not go
That
through
is
the
where the
prongs.
reading is happening.
Yes. So if you have a patient that needs to be on high flow, so if you're like pre-oxygenating or like whatever it is, and you want them on high flow, which means greater than 6 liters, end tidal CO2 cannula cannot deliver that.
Where is the oxygen coming out of?
There's little holes like right at the
Yes.
base of the nose.
It's little holes. It looks like a shower head.
Yeah.
It's like blow by for adults.
Yeah. So just keep that in mind. And if you crank it up really high, it is going to wash out your...
Yeah.
Or some have it where one nostril, which I don't like these because you could have like a nose hole that's clogged out or a deviated septum. But some of them, one nose hole is, one prong is giving oxygen and one is receiving readings. So just keep that in mind. Yeah, that could, those aren't as common.
All right, so next scenario. Let's talk about the thing that I think that end tidal is most known for and is like people really hammer down on. You should use it absolutely every time, and they are correct.
They are correct.
Intubation and the confirmation of such intubation. So waveform is how you prove that your tube is in place and it is working. It is the number that if anyone says your tube is not good, you can say with an end tidal of 33, yes, it absolutely is. Right? So your things that you need are a sustained waveform that is in the appropriate shape, and you need to trend your numbers. Now, trending is important, right? If you just have one end tidal reading, that's not going to do much for you.
Right.
The trend of your end tidal is important. Now, what are you going to see if your tube is in the esophagus and it is on end tidal?
Nothing.
Not good things.
Absolutely. You will have no waveform. There will be no waveform. There will be no numbers because there is no ventilation happening in your tummy.
So, as far as your waveform, if you are in the trachea, if you have a correct tube placement, that waveform is now up to you. It is dependent on you. So, it will reflect what you are ventilating with your BVM or what you have on your ventilator. And then your actual reading, your numeric reading, is going to reflect the status of your patient.
Absolutely. So, like, what if I just have, like, a color metric? Isn't that the same thing?
Isn't that the same thing?
Get out of here.
Colorimetrics are really good for one reason. If you are in a place where your monitor cannot fit and you have to intubate a patient, that is really the only time that I can think of that, like, you should be relying on a colorimetric.
Right.
Because we have the digital version of a colorimetric now. It's called waveform end title.
Right. I made a big mistake a few years back in that my argument was that we should just throw colorimetrics in the trash can and only use end title. And everybody that loves colorimetrics got real grumps about that. Instead of presenting that you can still use your colorimetric that gives you the warm and fuzzies and then put on an end title.
Yeah.
That way you have your waveform, because colorimetric confirms your tube placement. End title confirms that your tube has remained correctly placed.
Correct.
Did you know you can get false readings on a colorimetric?
Say it ain't so.
You can. How might that be? It would be kind of, it's like not going to happen every day. But when you have been ventilating for a long time, before you've intubated, it can get pretty gassy in that belly. That's one way. Vomit or like super acidic gastric contents or secretions, they can trigger a color change, which is, the color change is yellow for those who are listening.
Urine.
Yeah, well, that's a good one. And then like certain chemicals, the patient has like ingested something and that's why we're needing to intubate or something. Acids, alcohol vapors, some cleaning agents, things like that can do that. And then poor perfusion states, not necessarily can they create like a false positive, but we can't really measure that with just like color change. So
Yeah.
I feel like you need more. And they use it often in the hospital. I feel like in the ER with RT, they just hop on, and that is odd to me.
You know, I've always thought it is really strange that hospitals do not monitor
Routinely.
end title routinely at all.
Yeah.
Even like RTs, they will not
just get
monitor their end titles on vents, and I
I would
appreciate.
I would pass away.
Right, I appreciate
Out
that
of
they
shock.
have access to ABGs, VBGs, all the blood
But
gases.
that's not continuous.
It's not continuous, and you know, I have been surprisingly surprised.
Surprisingly surprised.
That ERs don't really care about continuous monitoring.
No, they have like a portable device that they'll bring in for.
Yeah, they like don't really monitor anything continuously. I will be like, hey, we brought in that patient that I was like, they may end up having a STEMI, and I'm like, where is there, like, have you done another EKG? And they're like, well, we just did the 10-minute one, and it was fine. I'm like, well, it's been an hour. Have we done another one? And they're like, what? And I'm like, what?
We're waiting on their troponin to come back.
But like that is always wild to me. They
Even
don't do a lot of continuous.
Well, that's a great point, right? Like, I know we're talking about end tidal, but I can't tell you how often I've had a transfer, and they did an EKG when they got there, and they're like, it's fine. Okay, it hasn't happened often. It happened about 3 times.
That's
and then
enough.
I did my EKG like hours later, and now it's not a non-STEMI. It is now a STEMI.
Mm-hmm.
So we're not going to a room now. We need to go to the cath lab now, or we need to go.
Yeah, because now I'm not
to the ER.
transferring an STEMI. I'm transferring a STEMI.
Right.
Mhm.
So it is so important to double check, even if you do have those ABGs, even if you have that information when you're leaving your transfer. Make sure you apply
sure.
end tidal and do those things.
Yeah, continuous monitoring is super valuable. And again, we talked about the benefit of trends. It gives you a solid trend that is not something that is cumbersome, like ABGs, VPGs, things like that.
Right. Come on, guys. If you're already doing all the things, you might as well just do one more thing.
Right? Might as well. Slap that little cannula on them.
Well, let's talk about more advanced scenarios, or more complex, I guess, or out of the way scenarios where you may use end tidal. Head injury. We like using it in head injury. We recently had a patient who was vented, breast stacking, and difficult to sedate, and I was watching that end tidal like a hawk. I was stressed. But your target end tidal for head injury is 35 to 40, and if they have occurrences of end tidals outside those window, it can increase mortality.
Right. Why would you want to keep an end tidal on the lower end of normal in a head injury?
Well, first of all, we want to break it down all the way to CPP?
Yeah.
Cerebral perfusion pressure. Let's talk about that before we get into the end tidal, because Cerebral perfusion pressure works by, so intrinsically when we are having some kind of brain injury, especially in bleeding situations, there's not a lot of space, right? Monroe-Kelly doctrine. In our brain, there's only a definite amount of space, and there is blood leaking into places where it's not supposed to be. So cerebral perfusion pressure is how we maintain adequate perfusion, obviously, to our brain. And to do that, we kind of have to have like an elevated blood pressure, for example. We kind of have to have, which we don't need to be hypercapnic, but we need to make sure that we aren't making any of these things too low, because there does need to be a certain amount of resistance inside our blood vessels in our brain. So when it comes to end tidal and managing end tidal, high CO2 is going to cause cerebral vasodilation. So it's going to increase your blood flow, which is going to increase your ICP, which is going to lower your cerebral perfusion pressure. And your CPP needs to be in a certain range. So when we are hypercapnic, we are potentially going to have a worse outcome because we just vasodilated and worsened our cerebral perfusion pressure. If we are hypocapnic, it's going to cause cerebral vasoconstriction, which can lower our ICP, and temporarily raise our CPP, but in the long run, it's going to cause ischemia. So your sweet spot is going to be 35 to 40, so the lower end of normal. You don't need to make it too high because we don't need to vasodilate, which I feel like in our brains when we talk about pressure, we are like, oh, vasodilate to reduce the pressure. It's just not like that.
No.
In our little noggins. It is the opposite.
Absolutely. You need a certain amount of pressure to actually perfuse.
Yes, and try not to reduce our end tidal too low, because that also is not good. Stop hyperventilating your patients with brain injuries. That's why it matters. I hope that made sense, and if it didn't, it wasn't me.
Basically, in head injuries, you are ventilating on the higher side of normal to be able to create more room, but the use of end tidal is your target, because it's not just how we learned in school where you just hyperventilate, you breathe once every 2 seconds, and you're hyperventilating the heck out of these patients. We now have a numeric target, is the point.
You ventilate on the higher side of normal to keep your end tidal on the lower side of normal.
Correct.
The most important phrase here is side of normal.
Yes.
In traumatic brain injury, every millimeter of CO2 is a millimeter of blood flow to the brain. If you drop the end tidal CO2 below 35, that mortality curve spikes. So ventilation isn't just breathing, it is brain.
Ooh, every millimeter of CO2
is, in a metaphorical kind of way, is blood flow to your brain.
Is blood flow to your brain.
I like that.
I like that too.
What about PE?
Oh, this is my favorite one. I have had many a rascally PE. It is like, it's a call that some people will never see. It's a call that we get literally all the time. It is just luck. Like, it just shows up on our doorstep.
I swear.
That's where all our clots are going. They're going to the lungs instead of the heart.
See,
that's why we have never had a STEMI.
That's why we've never had a STEMI. All right, so PEs, they're going to have a normal respiratory rate, but they're going to have a very low end tidal. And so I would say normal to high normal to higher respiratory rate, but a lot of times that's only because they're anxious. If you have unexplained anxiety in your patient, start thinking PE, because they present so strange. But normal to a little bit higher respiratory rate with a really low end tidal, that means that you have dead space in your lungs. And so that is where like a lot of your VQ mismatch comes into play. So if you have your PE, it's not a ventilatory issue, right? Well, technically, but like it's not an inspiration expiration issue, because they can breathe in fine, but there's a clot that is preventing blood from going to their alveoli so that they do not actually have any gas exchange. That's why you're going to have a super low end tidal, because there is no to minimal gas exchange happening.
Yeah. I think that's important, that if you have a young female patient who's anxious, for no reason, put them on end tidal.
Absolutely.
And just because they have a low end tidal does not mean they have PE.
No, there's some other indicators, and there's like plenty of things to learn about a PE. and some other EKG changes that you can see, some very like stark, some quite nuanced. But if you have a patient that has any propensity for clots or they have any risk factors, so African American young females that are on birth control, get to thinking.
If they have literally any medical condition ever and they're on birth control.
If they're on birth control.
Yeah.
If they're a girl.
Right. If they're a female in their 40s and are diabetic or like really any of these risk factors that we think of for other things, they're risk factors for clotting, which means they're risk factors for PE.
Correct.
So be concerned because these patients will compensate, and then crash. It is very much like a pediatric. They will look fine, and then they will be dead.
They will turn purple.
Yep.
So what about, we've talked about all of this now. What about end tidal, just like in EMS culture? I know this is a battle we fight a lot.
Yeah.
I just feel like we need to stop treating end tidal like it's extra. Like it's not extra credit.
Yes.
It's not bonus points. It is just a basic assessment tool.
I think that if you have an ALS call, end tidal CO2 should be considered a vital sign.
Yeah, absolutely.
That's it. I'm not saying that your knee pains and toe pains and the 2 a.m. I'm colds necessarily have to have end tidal on them. Because this is within reason. We're not trying to burn everybody out. But end tidal is as important to me as your heart rate and your blood pressure.
Yeah, it's part of your clinical decision making using that tool. Like if you don't have that, you don't have all the picture that you could have.
Yeah. Why would you not want to collect more data, more information?
It doesn't even compute for me.
I know that we have already likened it to this, but it's the same as when like they first started getting like 3 leads on the truck, and all they had was just like the running lead, and then they eventually got 12 leads, and they're like, I imagine, because we still hear it sometimes, that if you don't see anything concerning on your running lead, why would I do a 12 lead?
Because
sort
you
of a
can't
situation.
see the whole picture, guys.
You cannot see the whole picture, and I think that you can liken that to your SpO2 and your heart rate. Well, if I don't see anything concerning there, why would I investigate any further? You are never going to regret investigating. No paramedic has ever said, I really wish I never did a 12 lead on that patient.
Or I wish I'd never put that SpO2 probe on them. What?
Yeah,
Yes,
like that's just not a thing.
The only reason you would ever say that is if you really wanted it to be a BLS call.
Yeah, exactly.
That is true, I suppose.
Man, I never should have got that blood pressure.
But
also,
I've heard plenty of people be like, well, I probably should have gotten a 12 lead on that
right,
patient.
if you think about so you have a human, right? Whole body, multiple body systems. You use your eyeballs to look at the entire body of this human, right? 12 lead. You have a heart. You have an entire heart that is a whole system in and of itself, multiple moving parts, multiple functionalities happening here. If you take a physical assessment and you say, well, this patient isn't injured, the only thing you look at is their right leg. You're like, the right leg's fine, so clearly their entire body's fine.
Yeah, that's weird, guys.
That is weird behavior. If you do the
weird.
same, that's the same thing with your running lead. If you do a 3 lead and you're like, well, the 3 lead's fine, well, that's taking one tiny snapshot of one tiny part of their heart. And if you are then going to surmise that the whole heart must be fine, then you're missing the point of a 12 lead. Because you cannot say that because one part is fine, the rest of the parts are fine.
Yes.
Because that's why the leads show different things in your 12 lead.
And when it's all said and done, like, and if some shit hits the fan and things start going wrong, don't you want to know that you assessed everything you could possibly assess?
Mm-hmm. And honestly, I'll be so super honest with you. I was like, I wouldn't say resistant to end tidal, but I did not see the benefit
Like the importance
of it. Yeah. Like when we got end tidal cannulas, I was like, cool, that's great. I always use end tidal in intubation. I was like, duh. But on like regular people, I did not see the benefit on just like my sick patients because nobody taught me the benefit.
There is
I
so
didn't
much
know.
pushback still.
Right. But like I just didn't know. Nobody taught me in school all of the benefits of end tidal because it wasn't a thing that was taught really. And then I got all these like sweet little new bean medics that I am now recording a podcast with. But like you guys came out and you're like, no, end tidal is a tool for so many more things.
Is important.
And even after I learned about it, I really had to see it in practice with Aubrey throwing everybody and their mom on end tidal.
Well, you could just learn more about it's like
yeah.
the
And she
more
would be
calls
like,
you run, the more you learn. The
She
more
would-
calls you run with end tidal, the more you learn how to use end tidal.
Yeah.
100%. Now we get patients where we'll put them on end tidal and we'll you know that feeling that you get where you're like vibes are off, like something's up. I just can't quite put my finger on what it is. We'll throw them on end tidal and be like, oh, that's what it is. Their end tidal's 15.
Yeah.
You know, like
oh, okay. That was the final puzzle piece.
yes, and it gives you a good list of differentials to start looking at.
And now that y'all have heard us just yak about just so many things, sorry if your brain hurts. Mine does. We had to take a meal break in the middle of this. That's how crazy it was. There's so much that you're not going to hear. But let's move on to my favorite part of the episode. Trivia! That means it's almost over.
Wow, I really missed out on that.
How'd you not see that coming?
I don't know.
All right, so you're working in cardiac arrest. Your ETCO₂ is 8 during compressions. What is your first concern?
Someone is tired and they're not doing compressions well.
Absolutely.
Correct. Or if you're using a Lucas device, auto pulse, some sort of mechanical CPR, you may want to check your positioning. And a great way to do that is to have somebody physically palpate a pulse while you position your mechanical CPR, and hopefully you will see an improvement in end tidal.
Absolutely. Where do you check for a palpable pulse during CPR?
Femoral.
Absolutely. Now you can check a carotid, but I'm going to tell you that the recoil from the actual device is going to do you a big bamboozle.
Yeah.
Be getting ROSC on air, buddy.
Yeah, you'd be like, we got a pulse. Then you'll hit pause and you'll be like, never mind.
It's not the most fun place to check, but it is one of the most reliable.
Right. So ideally we want to aim for greater than 10 during compressions. That gives you a good idea that your compressions are sufficient. There is definitely a place and time in which your end tidal, even with really good compressions, is going to be under 10. That is a decent indicator that your patient's had a prolonged downtime and this resuscitation may not be viable. Now, depending on your protocols and what that looks like for you, there may or may not be anything you can do about that. But just because if you have checked all of your bases, like you have checked that, look, we are doing compressions, we have a pulse with compressions, like you've really gone through and made sure everything is sufficient, your end tidal remains under 10, that may be why. So, bottom line for this one is that end tidal CO2 is your real-time CPR quality monitor.
And if you're not using it, that's weird, bro.
Weird vibe.
Weird behavior.
All right, let's say you intubate a patient, you see a waveform with a sharp peak and a slanted shark fin shape. What condition are we now honing in on to treat?
Obstructive disease.
Yeah, like a bronchospasm.
Yeah. So anytime that you see that morphology in your waveform, always think like asthma, COPD, and then go from there. So do all your normal asthma, COPD protocols. Doesn't stop with intubation. You're not fixing the problem. You still got to fix the problem.
Both show.
You have a trauma patient who still has a normal blood pressure and heart rate, but end tidal CO2 drops from 36 to 22. What is your next thought?
And they're bleeding somewhere.
Yeah.
They are just bleeding.
They're just bleeding.
Yeah, you are showing signs of shock. And to expound, poor perfusion.
Yeah. Red flag. It's a super big red flag, but it's also a supporting role, I suppose, in making the decision whether this patient needs access to blood or not.
Absolutely.
So when you're looking at end tidal, very often your end tidal is going to be the thing that drops before anything else. So keep an eye on her.
Yeah.
All right, and last but not least, let's talk about DKA. They're breathing fast, and their end tidal is 18. Should you intubate right away?
No, bro.
We just really wanted to hit this home, I think.
No,
We just really
bro.
want to be making sure that nobody is doing this.
Please don't do that.
Yes, they are compensating. Killing their respiratory drive equals a disaster.
If they are compensating through respiratory drive, rate, and pattern, and it's not a respiratory issue, don't intubate them.
Yes.
Because they could have... I've seen this before. Intubation of a antifreeze patient. They present kind of similar to these advanced TKA patients. Don't do that either. So,
No
if it is
bueno.
metabolic, don't intubate.
Yeah, don't snatch
Immediately.
that from them.
Wait, okay?
Absolutely. These patients should absolutely 100,000% bully you into taking their airway.
Yes, they have to force your hand.
Yes, if you ever have to intubate these patients, it should be their idea, not yours. Their
Yeah.
presentation needs to be so bad that you're like,
Oh,
there's no
damn
way
it.
that I cannot manage
Yeah,
this.
you're like, dang, I didn't want to do that, but here we are.
Right, but their respiratory rate should not be your indicator.
Absolutely. So do all the other things. Fluid, if you have insulin, obviously, but we're not going to really see that pre-hospital. And then just monitor. You know,
Yeah.
be prepared for the worst. But don't impede their compensation with a tube.
All right, Albs, wrap her up.
If your patient has a tube, a pulse, or not, end title should be telling you a story, and you had better use it.
Please.
Yeah, please.
Okay, bye.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.